I am Dr. Benjamin Levy. I'm a thoracic medical oncologist at Johns Hopkins School of Medicine, and maybe we can just go around the room and introduce one another.
My name is Dr. Wally Kern. I'm a radiation oncologist. I'm the Chief Medical Officer for Genesis Care, and I'm also Professor Emeritus at Emory University.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Radiology and Vice Chair for Education at Memorial Sloan Kettering Cancer Center. And I'm also a Professor of Radiology at Weill Cornell Medical College.
Mike Lanuti. I'm a thoracic surgeon at Massachusetts General Hospital in Boston. I'm the Director of Thoracic Oncology for our Division of Thoracic Surgery. Also have an adjunct associate professor at Harvard Medical School.
I'm Ramaswamy Govindan, a medical oncologist with interest in lung cancer. I'm a professor of medicine at Washington University in St. Louis.
68-year-old male, current smoker, 35-pack year with a prior T1N2 adenocarcinoma of the right upper lobe. The PD-L1 at that time was 80%. There were no mutations. The patient appropriately underwent concurrent chemoradiation in 2014. He now presents with local regional recurrence in the right upper lobe and the right posterior hilum, at least partially infield. So here we go again with some questions about how to manage recurrence. Is pneumonectomy an option? How would previous radiation and right-sided disease affect his operative risk? Good question. Surgery is not an option. Are there radiation options? So let's go through the case. And again, this case will then peel off and we'll do 6 additional scenarios. So this is a patient initial presentation. He had really no symptoms. His ECOG performance status was 0. He has a history of COPD and coronary artery disease. He's a current smoker with a 35-pack year history and no family history of cancer. In 2014, he had a PET. We don't have those images here that showed 1.2 centimeter right upper lobe mass and a 6 centimeter hypermetabolic right side mediastinal node conglomerate. The EBUS biopsy in 2014 was consistent with adenocarcinoma. I see some radiation planning here in 2015. Dr. Kieran, I don't look at these images that much. I mean, can you kind of walk us through, maybe with Dr. Ginsberg, maybe how you plan these, or maybe we'll start with Dr. Ginsberg. I don't know if you can really see or delineate a lot of this with all the planning here, but maybe talk to us about what you're seeing first, Dr. Ginsberg, and then we'll get to Dr. Kieran.
So we do see the paratracheal adenopathy, which is quite large, and it's in the field. We don't really see on these windows the upper lobe nodule because they're just not windowed for that. But it looks like the field does extend into the right upper lobe on the left-hand image, which presumably includes that right upper lobe nodule.
Great. Dr. Kieran, just some brief overview of the planning here that we're seeing.
Yeah, so the numbers that range from 50 to 110 are not centigrade or rad. They're actually percent of the defined dose. So the red area is where 100% of the planned dose was given. So let's say for the sake of argument, that was 60 gray. Then areas that are down in, let's say, turquoise would have gotten 36 gray. So, you know, that's a pretty high dose for a large part of the lung. I think the view on the left really gives us a better idea that the ipsilateral mediastinum got 60 gray. The full mediastinum got somewhere between 55 and 60. And at least based on the cut we're looking at, it does not look like a large volume of the lung got full dose. But based on the turquoise isodose lines, a lot of lung got some intermediate, relatively high dose, like 35 to 40 gray. Okay. So I would worry about the fact that, you know, the lungs have already gotten a pretty good hit of radiation.
Okay, that will play obviously into the questions that are being asked when we see the next few slides. So thank you for making that point. So the patient undergoes concurrent chemoradiation, and then fast forward to 2020. We see an interval increase in the size of the right upper lobe and right parahilar nodes or nodules with surrounding radiation changes. So the recommendation is to get a short interval PET scan, which is done. And maybe we can look at the PET, and Dr. Ginsburg can go over that, and we can just see what the read is. So I'll fast forward here for Dr. Ginsburg and kind of walk us through the PET scan findings.
So we see a very avid right upper lobe mass in the right-hand image. And then on the left-hand image, you see that there's also a mass more posterior to the hilum, probably in the superior segment of the right lower lobe. Some of this could be within the radiation field and therefore some radiation uptake, but the very focal uptake is extremely suspicious and consistent with recurrent disease.
Great, and this is just the other cuts here?
These are just coronal images demonstrating the same thing, the right upper lobe mass, and then you see a band like some of this is also radiation pneumonitis, but most of this is consistent. This is recurrence.
Great. Okay, thank you, Dr. Ginsburg. So as Dr. Ginsburg mentioned, the PET-CT confirms an increased size of the right upper lobe mass. It's 4.5 centimeters, it's hot. There's also a right posterior parahilar mass that Mel measures 4.4 centimeters. That's also quite FDG avid. An MRI of the brain is done that shows no evidence of metastatic disease. An EBUS is done of the right posterior hilar mass. It's consistent with adenocarcinoma. Molecular testing is done. It's negative, and the PD-L1 is 80. Patient has PFTs that show an FEV1 of 70%, an FEV1 FVC of 60, and a DLC of 65%. So recurrence after local recurrence, after concurrent chemoradiation. And I guess the question here is first to surgery, to Dr. Lanuti. How would you approach this, and is pneumonectomy a possibility? Does previous radiation play a role in your decision-making, and right-sided disease play a role into his operative risk?
Yeah, so surgeons that evaluate this are looking at, local control, and could you salvage this in a safe way? That is there any other local option here aside from surgery? And it sounds like there isn't, unless Dr. Kern tells me differently. And so, people get a discount from radiation if it's 6 years ago, but I don't know if you could get a high enough dose to treat this recurrence. Nonetheless, you'd want to put this patient through sort of a fitness assessment, as always, with, the PFTs would suggest that they probably could tolerate even up to a pneumonectomy. I'd like to see them in front of my eyes where they could walk up a few flights of stairs without desaturating, and that they have an echocardiogram that's adequate without pulmonary hypertension. You would want to really do if you could, a salvage right upper lobe without having to take out the entire lung. The caveat being is if there is some disease in that superior segment, right lower lobe, could you wedge it out? Do you really need to do a pneumonectomy? You really have to nail that down. And I'll tell you why. So complications around previous chemoradiotherapy for surgery are higher. That is, and highest when it comes to pneumonectomy, particularly on the right. So the mortality in good hands in experienced centers of a traditional right pneumonectomy in the absence of chemo-RT is somewhere in the range of 3 to 6% mortality, perioperative mortality, 90-day mortality. If you add in chemo-RT from years ago, you're pushing that up into the 10, even 15% range of mortality perioperatively. There's a real risk of death here. And so, that's a careful conversation with the patient of if they could tolerate a pneumonectomy, understanding the risks is number one.
Great. If surgery is not an option or not felt to be a surgical, couldn't be safely done, surgery couldn't be safely done, is there a role for radiation here? And if so, can we re-irradiate? Is there a role for protons? These are the questions I think come up with us a lot. Dr. Curran, your thoughts on this?
Sure. So, one way to think about this patient, if surgery is not possible, would be with the very high PD-L1 number. Might this be a patient where you truly might get some mileage out of a checkpoint inhibitor or even a doublet for a while? followed by radiation. And this truly might be a patient where you really would get response. If you can really define a target, and the target is far enough away from critical mediastinal structures, and the value of proton or the value of a very precise modality like that, which spares tissues between the target and the skin. Really, I think this might be a good case for evaluating proton. And the way that we have been able to do it at Emory, we can have a patient undergo a single treatment planning CT with motion, look at how much the target moves, and compare a proton versus an IMRT plan. But I'd love to see a patient like this have response to checkpoint inhibitor and then evaluate if non-operative approach is needed.
Dr. Govindan, your thoughts on if this patient was recurrent and seems to be locally recurrent after concurrent chemoradiation, high PD-L1, as Dr. Kieran was talking about the role of potential a checkpoint inhibitor, would you feel comfortable doing that? And if so, for how long? And when would you reassess response?
All great questions. So there are two scenarios. One is a sort of induction approach followed by radiation treatment. Second is in lieu of any local therapy, just pure systemic therapy. The first case scenario Dr. Karan was highlighting is that can we give some induction therapy? My question would be, to what purpose? If the idea is to shrink the tumor and then make the radiation target smaller, I think it's certainly something where you can go for. And in that scenario, you could argue that the time-tested traditional approach is not a PD-L1 inhibitor therapy approach. After all, the concurrent chemoradiation as its genesis, beginning as a sequential approach before Dr. Karan did his seminal study of concurrent chemoradiation. So a traditional approach would be to give induction chemotherapy after 2 to 4 cycles, reevaluate and do radiation therapy, very similar to the old Dillman study where patients got cis and vinca alkaloids along with for 2 cycles for the radiation treatment. So if you really want to stay closer to what has been time tested, would be that kind of an approach where you give a couple of 2 to 4 cycles of induction therapy, conventional chemotherapy regimens with a doublet of choice, in this instance, pemetrexed, carboplatin, or whatever choice one would pick. I probably would stay away from gemcitabine-based combination, although a lot of people have moved away from that. Gemcitabine has the potential to do what is well known as radiation recall, and we have seen some dramatic instances of radiation recall even years after. So I probably would use a non-gemcitabine-based induction therapy for adenocarcinoma for ease and convenience. I would give pemetrexed carboplatin after 2 to 4 cycles, reevaluate, and send this patient to Dr. Karan. That would be my approach if it is done in the induction fashion. Having said that, could you give induction checkpoint blockade given the fact that the PD-L1 expression is 80%? I suppose you can, but this is completely unproven, and we have not done this barring a few neoadjuvant studies prior to operation that have been published that shows some dramatic response in terms of radiation necrosis. So I'm not opposed to that, but it would be unconventional in my view. On the other hand, if radiation is never going to be possible, it is still somewhat discomforting that we have to subject somebody to the toxicities of systemic therapy for a disease that is so localized, somewhat indolent, having grown after about 6 years. But obviously, patients get distressed with a growing disease, and when surgery and radiation is not possible, I think for a lesion that has been observed to grow under the watchful eyes within a short time, I think systemic therapy in that scenario is not completely unreasonable. So here, given the high PD-L1 expression and the interest of minimizing toxicities, I would favor giving single-agent pembrolizumab, and I would give it for up to 2 years and not continually beyond, if the patient tolerates it and has no disease progression. And that's how I would approach. The whole idea is to minimize toxicities and then have a finite duration in this setting of localized therapy.
Great summary. So let's finish this up. So In terms of decision-making from the group here, it seems like this patient needs to undergo the fitness test and eyeball test by the surgeon and a conversation about surgery, depending on those factors, with the consideration of a salvage upper lobe. In the absence of surgery, radiation seems like it could be used. If it is used, potentially medical oncology could give 2 to 4 cycles of chemo as induction if radiation is going to be used. But the point being, you probably wouldn't consider using immunotherapy given the lack of data. And if that radiation is not going to be considered, maybe giving pembro or consider giving pembro for up to 2 years, given that the PD-L1 was high. Okay, so we're going to move on to the severe. Yes.
One other comment, sorry to interrupt, but
No problem.
in the history, it noted the patient was still smoking. So I think I'm sure that Dr. Lanuti would feel it's really mandatory to stop before really considering surgery. I would also say the same thing as it relates to radiation. High-risk radiation procedure is a much higher risk if the patient continues to smoke.
Great point.